Thank you for joining us for this Targeted Oncology Virtual Tumor Board, which is focused on ovarian cancer. In today's Targeted Oncology Virtual Tumor Board presentation, my colleagues and I will review 4 clinical cases. We will discuss an individualized approach to treatment for each patient and will review key trial data that impacts our decisions. I am Dr. Robert Coleman, Professor of the Department of Gynecologic Oncology and Reproductive Medicine and Executive Director of the MD Anderson Cancer Network Research and the Ann Rife Cox Chair in Gynecology at the University of Texas MD Anderson Cancer Center in Houston, Texas. Today I'm joined by Dr. Susana M. Campos, Assistant Professor of Medicine in the Division of Medical Oncology at Dana-Farber Cancer Institute at Harvard Medical School in Boston, Massachusetts. Dr. David O'Malley, Medical Director of Gynecologic Oncology, Director of Clinical Research of Gynecologic Oncology, Co-Director in the Gynecologic Oncology Phase 1 program, and Professor at The Ohio State University and the James Cancer Center in Columbus, Ohio. Dr. Gregory Rielinger, Assistant Professor of Pathology in the Division of Translational Pathology at Rutgers Cancer Institute of New Jersey and Rutgers Robert Wood Johnson Medical School in New Brunswick, New Jersey. And Dr. Shannon N. Weston, Associate Professor and Director of Early Drug Development in the Department of Gynecologic Oncology and Reproductive Medicine at the University of Texas MD Anderson Cancer Center in Houston, Texas. Thank you for joining us. Let's get started with our first case. Okay, our first case will be discussed by Dr. Susana Campos. Why don't you take it away, Susan?
Thanks. So I'd like to share with you guys a case that's quite interesting. It's a 44-year-old premenopausal woman that presented to her gynecologist complaining of weakness, vague abdominal discomfort, about a duration of about 4 months. Her past medical history is namely unremarkable. She has 2 children and has always had a normal menstrual cycle. In terms of her family history, both her parents are living, lung cancer on her father's side. On a physical examination, what was dominant was really a right-sided abdominal tenderness and swelling. Imaging studies were done which showed a right-side solid cystic and adnexal mass measuring about 8.8 centimeters in size. There was periaortic lymphadenopathy, omental caking, a solitary liver lesion, and a splenic mass. A percutaneous biopsy did show high-grade ovarian adenocarcinoma.
Okay, so it's a good case, one we see frequently, and I think probably the first thing I wanted to maybe get a discussion about is to talk a little bit about the pathology. So give us kind of your thoughts on what you think about this pathology.
So typically as a pathologist, we're just looking at tissue initially on an H&E slide. There are certain morphologic features we're thinking about depending on specific diseases. In this case, they're saying high-grade ovarian cancer. So we're looking usually for more of like a serous morphology, and then it's an adenocarcinoma, so it's a gland-forming tumor, and the pathologist isn't going to go any further than that without immunohistochemistry. So you're going to be flying a little bit blind. So typically, the pathologists use a panel of markers, so a PAX8 transcription factor to kind of confirm that it's malarian origin. And then, with the high-grade serous, they tend to uniformly actually have p53 mutation. So on immunohistochemistry, there's actually two phenotypes. So there's the high expressors where all of the tumor cells would have p53, or the null phenotype where none of the cells have p53. And actually, when we do further molecular testing, this correlates with the actual underlying p53 mutation we see. So with the p53 missense mutations, these are always the high expressors. So that actually stabilizes the p53 protein, whereas the p53 frame shift or truncating correlate with loss of function, and so that's kind of consistent with a high grade serous. With quote unquote on ovarian, a lot of times we'll use a marker like WT1, and that's kind of what tends to be seen a little bit more in somewhere in the peritoneum, indicating a peritoneal origin. But there is kind of extensive literature now that what's called at least the so-called high-grade serous ovarian carcinoma really originate in the fallopian tube. So, women had been getting prophylactic BSOs who were germline BRCA1 and BRCA2 carriers, And a number of groups set up protocols to really section through the end of the fallopian tube and look for lesions there.
Yeah.
And they found, the kind of these so-called serous tubal intraepithelial carcinomas, which were believed to be really the potentially the origin for these ovarian carcinomas. And then actually work that came out, I think, in Nature Communications from Victor Velasco and Ronnie Drapkin,
Yeah.
where they actually went and so even before the serous tubal intraepithelial carcinoma, which would be a morphologic diagnosis, you can perform a p53 immunostain and see a precursor lesion.
Yeah.
And so it was really beautiful work where they went with a number of diagnosed ovarian cancers and that actually had metastasized, and went from these p53 precursor lesions, performed laser capture microdissection on p53 immunostain, the stick lesions, the ovarian cancers, and then the metastasis, and showed that these basically all have the same truncal origin, and as they spread, they acquire additional mutations, showing that really with the quote unquote high grade serous ovarian cancers, that they're originating in the fallopian tubes.
That's a really important distinction. I think, I think that this is an area that's evolved, and everybody puts up a textbook. They talk about ovarian cancer, and they still talk about the origin on the surface of the ovary. And so I think it's an important discussion. I appreciate that feedback.